Good afternoon. It's afternoon in São Paulo, and we are going to talk about the controlled mechanical ventilatory support in COVID patients. And we have had a very intense experience here in São Paulo. As you know, we are still in a big plateau of cases with high mortality. At this point, we have 800 deaths per day. So we are still seeing lots of patients with COVID, and we are going to share our experience and some research we are doing in the middle of this pandemic. So the main clinical findings in COVID have been described along these 8 months. Some of them are here and some of them are being challenged. So you have severe hypoxemia, no doubts about this. Most patients don't have hypercapnia at the beginning of the disease. They start with a quite good compliance, and this has been debatable. This has been debated, but it's quite sure that there is a difference, and we are going to talk about this. This is unquestionable. It's a prolonged course. It's 2 or 3 weeks, and some patients, you have to be patient to deal with 6 weeks or 8 weeks of mechanical ventilation. There is some initial information that secondary infection was very frequent, and lots of problems with coagulation that we are going to address. We have had some questions about the problem of good compliance and if this constitutes a new entity. We are going to talk about this. Secondary infection. Some people has challenged this approach, and some people still believe that we have some other viral pneumonias like influenza. They have more secondary infections than COVID, but this is not negligible. And then coagulation, it's a hot topic, especially because we don't know very well what we should be doing. Coagulation. So this has been an important topic to understand why some patients having quite normal X-ray, they have tremendous hypoxia. And some pathological studies, autopsy studies performed in our university, and have shown that there is clots all over the capillary network in the lung. And sometimes without a macro or a big thrombi in the pulmonary artery. So it's a minor microcirculatory thrombi, and then you don't have pulmonary thromboemboli like in trauma or in conventional patients. And this is an important topic because the management could be a little bit different. Also, no doubt that we have very high inflammation. PET studies have shown that we have a tremendous activity. So glucose utilization because of neutrophils. This coincides with the ground glass opacities. So it's filled with neutrophils and macrophages that are activated. And this is illustration what you can find in the PET studies. So very severe inflammation. In some patients, you have the classic thromboemboli in the pulmonary artery causing life-threatening situations. So this particular patient has a big thromboemboli in this pulmonary artery. You can see even the clots coming from the inferior vena cava or femoral vein. And something very interesting to understand is that typically you see this kind of ground glass opacification, and when you go to dual source CT, you can have a representation of the blood flow or blood volume. And as you can see here, all this ground glass area doesn't have too much blood. So there is no specific clotting in any big vessel, but all this region has probably some microcirculatory thrombi, and then this is causing this big lack of perfusion in this area. And if you pay attention, you see that you have a enhancement of contrast in the periphery of this obstructed region. And this is exactly the explanation for the hypoxemia. And this is something that we have understood a little bit better with the use of electrical impedance tomography. So this is an image that we published very recently in the Blue Journal. You can see a patient that had some thrombi in the pulmonary artery. You can see here in the angiography. We have also some contrast coming here to this atelectatic zone, as you can see. And then when we do a VQ map, so ventilation to perfusion map using electrical impedance tomography, we can understand the reason for the very severe hypoxia in this patient. You can see here that in blue, we are representing dead space areas, which means that these areas, they have normal ventilation, as you can see here in this map, but absolutely no perfusion. And then you have some regions that have normal matching. And then these regions in red, and especially those here in very brown or dark red, in which you have complete shunt, which means that these areas are precisely the ones that are generating the hypoxemia. Now you can understand what is going on here. So this patient has occlusion of vessels in all these blue areas. This is causing a dead space effect, but not hypoxemia per se. So hypoxemia is coming from the hyperflow diverted to the right lung because these vessels are preserved. So it's precisely this perfusion of these atelectatic areas that is causing this shunt. So it's a diversion of the flow from the occluded areas that is causing the hypoxemia. And this is why it's very difficult to understand why some patients with normal vessel, normal X-rays or almost normal CT, they have tremendous hypoxemia because you don't see precisely the mismatch that is happening at the microcirculatory level. Something else that we have learned, and this is a very recent publication in Lancet, and they have performed some angiography with dual source CT. And then you can see here patients with very low perfusion of the lung and very low, and these patients, they had normal perfusion because this is in red. And these patients, they had very low D-dimer levels. And then these patients contrast with a second population of patients in which D-dimers were very high. And then you see these blue areas coinciding with areas in which the perfusion is very poor. And then, so you can classify patients according to lung perfusion and D-dimers. So high D-dimer, low perfusion, and vice versa. And when you have low D-dimer, you have a good perfusion. And then you can classify patients in low compliance on the left and normal compliance on the right. And it's interesting then that you can have these four categories. And these, one category here has a very bad prognosis, which is this one, the C one. So it's especially a patient with low compliance, high D-dimers, and very irregular or heterogeneous lung perfusion are the ones with have very bad prognosis. And you can find macroscopic thrombi in these patients. And this is the survival curve of those patients in which you have low lung perfusion in many big areas of the lung, so high D-dimers, and against all the rest of the patients. So these are the ones that you have to be very much concerned. And in fact, these patients, they have a combination of thrombi and low lung compliance. These are the worst patients to ventilate because they have tremendous hypoxemia caused by the thrombi, but also they have tremendous dead space caused by, not by the hyperperfused areas that have the diverted flow, but caused by the dead space in the very much occluded areas. So then you have a high PCO2 and it's very difficult to handle these patients clinically. So COVID has been recognized as a vascular disorder. There is no more doubt about this. And it's very common to see a patient that is having problems after the removal of sedation because they can have some problems in the brain, the perfusion of the brain with ischemic or hemorrhagic problems in the brain circulation. And this is happening all over the body, including the heart, the guts, and especially the lung, as we know. So sometimes you can recover from acute respiratory failure, but this patient is going to be a very reserved prognosis because of the rest of the body. And we have had many cases like this. So unfortunately, we had the hope that anticoagulation would help us, but there is some very recent data that is not suggesting this. It's still not randomized, but this is the best evidence we have for now. Paper publishing in Journal of American College of Cardiology. And then you can see here cumulative incidence or mortality. And these big mortality approaching 40% are those patients that did not receive any anticoagulation. And then these two lines they fit almost together. These are patients receiving either prophylactic or therapeutic anticoagulation. And as you can see, very minor difference. Okay, you can improve a little bit the prognosis by giving full anticoagulation, but this is not significant, which means that some advices to give full anticoagulation for these patients cannot help us too much. We can just improve above, let's say, the placebo effect, but unfortunately a higher dose has not been helpful up to now. This is a problem because we certainly see many patients with thromboembolic problems, big clinical problems, but doesn't mean that we can go straight forward to full anticoagulation or even a little bit more intensive anticoagulation. And finally, this famous cytokine storm, it has been propagated in the media and among physicians. This concept has also been challenged because some researchers, they have shown that the levels of cytokines that we can encounter in these patients are not so high. And there are many more patients with higher levels of cytokines than patients with COVID. And we don't have anything particularly new here. And this is very important because now there is a very new hypotheses coming from studies, genetic studies in supercomputers, telling us that what seems to be a big inflammation in the body is not exactly cytokines, but is bradykinin. And then there is lots of bradykinins in the body, and this substance alters the permeability of the vessels all over the body. So this seems to be associated with a moderate level of cytokine, and this conjunction of factors is going to cause the vascular problems that we see all the time. So it's not only cytokine. And this is very important because this brings us new possibilities for treatment of these patients. So, summarizing up to now, we have challenged a little bit the hyperinflammation because it's inflammation but not caused by cytokine storm only, okay? The thromboemboli problems cannot be solved easily with more intense anticoagulation. Secondary infection is not that often. In fact, we have seen lots of patients for many days along the mechanical ventilation without any need of systemic antibiotics except for ventilator-associated pneumonia. And so you have to do a close observation before giving antibiotics to these patients. And just a few more words about the good compliance, especially good compliance in these patients. So this is the original report from the Italian researchers showing that the average compliance in these patients is about 50, despite the fact that they had very high shunt levels, around 50%. So this is a little bit higher median value than found in conventional or traditional ARDS. And this is true. This was confirmed in this recent publication. So first you see the histogram of compliance of patients from LungSafe study, a big survey of patients with common ARDS, traditional or classical ARDS. And this is the histogram of compliance in patients with COVID. As you can see, there is a displacement to higher values of compliance, but it's not completely different. So there is a big overlap, and you find patients all over the spectrum of compliance, and this is very important. I think much more important than this is the evolution of compliance along the time. And as you can see here, this is the time from intubation, and as time passes, so we are here at the second week, compliance is going down for the same patients in this cohort. And so you have to understand why this is happening. And nowadays, we know that this is caused by two main factors. One, lung fibrosis. Second, decubitus atelectasis. And this is very important because the second one, but maybe a little bit of the first one, we can avoid if we have the right strategy. And this is exactly what we are going to be talking about today. So individual patients, the same graph, you see that along the time, compliance is going down, and this is remarkable. It's very common in our ICU that we do the admission of the patient with 45 of compliance, and then after 10 days, no matter what we do, after trying recruiting maneuvers, our compliance is 20 or even 15 mLs per centimeter of water. So this is why I like to say that if you want to propose a general strategy for those patients, you have to think about a long-term general anesthesia, about 3 weeks. And you have to plan for 3 weeks, because if you are successful earlier, the better. But typically, a typical patient and severe patient is going to last in your hands for 3 weeks. And then you have to think about what we could be doing to avoid problems during a long-term general anesthesia, because we have the problems of sedation and we have a very important problem of decubitus atelectasis. Any patient under anesthesia suffers from atelectasis, and you can imagine what happens in this patient for 3 weeks under mechanical ventilation. And people sometimes, they think that just by applying a certain level of PEEP, they are avoiding the problem. But this is absolutely not true. There are some signals in the CT that this problem is happening to your patient. For instance, when you started to see these dorsal consolidations, and especially if they go all over the dorsal face of the lung, this is a suggestion that your PEEP level is insufficient to avoid decubitus atelectasis. And then the situation can progress, and then you have very severe collapse, which can evolve to lung fibrosis. And if you allow this collapse to remain so for 3 or 4 days, it's going to be very difficult to reverse this later on. And then you have situations like this patient in which collapse cannot be reversed. We cannot have a reversal of this collapse, and you are indeed missing the gravitational orientation of collapse. How to avoid decubitus atelectasis? This is not an easy problem, but there is some solution for this in the recent years. So in this paper that we published 1 year ago, we are showing that if you take patients during laparoscopic surgery, a well-known surgery that causes lots of pulmonary problems and atelectasis, you can avoid atelectasis by using the right amount of PEEP, not exactly high PEEP, but just enough to avoid atelectasis. So what we did is that we titrated PEEP according to electrical impedance tomography. We kept this PEEP all over surgery, and then at the end of surgery, we could avoid the big collapse in the control group. So this is the control group in our hospital, which received 4 or 5 centimeters of water PEEP. During the operating theater, we detected this with atelectasis, but we kept the strategy because it was the traditional strategy in our center. And at the end, we had this big atelectasis after extubations. You see, so this CT was taken after extubation, which means that extubation, coughing, physiotherapy does not reverse these in 1 day. And this is a persisting problem. And then you can imagine what happens after 1 week of mechanical ventilation. In contrast, patients in which we titrated PEEP during anesthesia, we just applied the right amount of PEEP at the end of surgery, no collapse. So how much PEEP we had to apply? Each dot here represents 1 patient. This is body mass index and the right PEEP chosen by electrical impedance tomography. As you can see, if I take body mass index of 28, there is a big dispersion of points. So the 1 patient needs 70 of PEEP, another patient needs just 7 of PEEP to have a minimal amount of atelectasis. There is a relationship with the body mass index. Obese patients, they need higher levels of PEEP, but it's not easy to predict at the bedside. And this is why we need better monitoring tools. Applying this strategy all over surgery allow us to avoid high driving pressures as found in the control group in red. So when we apply this individualized strategy, we could have a much lower driving pressure, about 6 centimeters of water lower, which is a lot. This is enough to avoid many clinical problems in those patients. And this has been demonstrated in many meta-analyses and review studies. the higher the driving pressure, especially when above 13 centimeters of water, the higher the probability of pulmonary complications after anesthesia. Why? Because of decubitus atelectasis causing baby lung during anesthesia, and this is going to increase your driving pressure. Also in a recent study performed with patients with postoperative cardiac surgery, we also shown that reversing atelectasis and finding the sweet spot of PEEP was enough to decrease the length of stay and decrease the length of stay in the hospital and in the ICU, with a very significant result published in JAMA, and decreasing pulmonary complications, for instance, the need of accessory oxygen or non-invasive ventilation. So much less patients, they were needing supplemental oxygen when we applied this individualized strategy. Very significant result. And you can imagine the consequences for a patient that is staying for 3 weeks under mechanical ventilation. And finally, you have to remember that despite the controversial results of high PEEP trials in recent studies, there is still convincing data in the literature showing that applying the right amount of PEEP, avoiding decubitus atelectasis in obese patients, can decrease mortality. This was not shown for patients with a normal body mass index because we are still missing the technology to do this, which is something that I'm going to talk about. So, summarizing up to now, we have a long-term anesthesia, which is going to last for 3 weeks. We have to buy time and oxygenation, avoiding decubitus atelectasis. We should not apply a systematic high PEEP because this is going to cause other problems, like problems with cardiac impairment and problems with pulmonary hyperdistension. So sometimes also, if you need a recruiting maneuver and your hemodynamic system is not in a good shape, you better change position, like using prone position or lateral position for a short period of time to work as a recruiting maneuver. And then if you apply the proper amount of PEEP afterwards, you can keep an open lung status without the need of a traditional recruiting maneuver. So, but the most important part of this strategy for this achievement is to individualize. You have to understand how much PEEP your patient need. And finally, in conjunction with the right amount of PEEP, I think a general protective strategy has to go along with another main strategy, which is to avoid high driving pressure. And this is extremely important during the assisted phase of mechanical ventilation. And this is a very complex topic, and I'm going to address a little bit here in this presentation and a little bit in the next presentation. Okay. So basically, we are talking about two main strategies. So the right amount of PEEP and individualized recruiting strategy, and avoiding high driving pressure, including the assisted phase of mechanical ventilation. Trying to apply this approach in COVID patients, we have started a randomized trial of mechanical ventilation. And this trial is going to go on until the end of this year. We have so far recruited already almost 40 patients. Let's see a little bit of the results. First of all, to our surprise, when we are finding the right PEEP for these patients using electrical impedance tomography, the first thing that was a little bit surprising is that we can increase oxygenation. So some people were saying that these patients were not responsive to PEEP. And I can understand this because sometimes when we apply excessive PEEP, you can have a deterioration of oxygenation. And also if you apply high PEEP in patients that don't have decubitus atelectasis, you are going to have just some worsening of oxygenation. But if you're applying the right amount of PEEP, you can still improve oxygenation in COVID patients. So it's not, so this is important. But very interesting, this improvement in oxygenation was much more related to the fact that we did not cause overdistension. Whenever we cause overdistension, oxygenation could deteriorate or not improve at all. So this is very important. For the first time, PEEP and improvements in oxygenation were not related to the decreasing lung collapse. And this is in absolute contrast with the rest of ARDS. Typically in a patient with ARDS, if you decrease collapse, you improve oxygenation. But for COVID patients, not. It's much more important to not cause overdistension. And this is why finding the right amount of PEEP is extremely important. How much PEEP is this? If you look at this box plot, you can see that it's not much. You see that no patient needed more than 20 of PEEP, but there is a big spreading between 7 and 20 centimeters of water, a little bit higher than what is advised by the ARDSNet table, the low PEEP FiO2 table, but not exactly high PEEP or super PEEP. It's just the right amount of PEEP. And you can have a kind of grasp this idea looking at this graph. These patients were initially at the ARDSNet PEEP, so using a PEEP FiO2 table, and then we titrated, let's say, the ideal PEEP using EIT. You can see that many patients had to increase PEEP, but some patients had to decrease PEEP to find the sweet spot which could decrease or minimize decubitus atelectasis and not causing hyperdistension at the same time. And so it's not exactly high PEEP, but it's the right amount of PEEP or the individual PEEP for these patients. Okay, in conjunction with this, we had many rules, and this protocol is being guided by a computer for us to have a very strict, to follow a strict protocol. But then we have a general strategy to avoid high effort, muscle effort from the patient to minimize the problems during the assisted phase of mechanical ventilation. Why? Because it's very common to see that some patients, they have a big improvement in lung function, they seem to be protected, they started to improve compliance oxygenation, but as soon as they start to have spontaneous ventilation under pressure support or volume assisted ventilation, we start to have problems. And at this moment, we have some general rules to avoid a big patient effort. Just to give you some examples. So we always consider that the total driving pressure is the sum of what the ventilator is doing, so your pressure support level plus what your patient is doing, the muscle pressure. So sometimes to avoid excessive driving pressure, we have just to decrease the pressure support levels down to 5 or 0 centimeters of water. Why? Because the priority is lung protection, not muscle protection at this moment of acute disease. We try to avoid too much acidosis to not stimulate a lot the ventilatory drive, so pH above 7.37. Sometimes during the beginning of pressure support, we increase PEEP level instead of decreasing it. Why? Because higher PEEP levels causing increased FRC can inhibit your ventilatory drive, according to many papers published by our group and by old physiologists. So sometimes a little bit PEEP can calm down the ventilatory drive and also decrease the efficiency of the diaphragm, and this is going to reduce your muscle driving pressure. Believe it or not, we have found that increasing FiO2 just a little bit to increase your PO2 above 60. So rising the PO2 from 60 to 85, 90 millimeters of mercury in some patients have a tremendous impact on the ventilatory drive. And when nothing of these or of the ones quoted above worked, we can start using propofol, which is the best agent to decrease muscle effort. And then if this is not working, we paralyze the patients again, even if the patient is already in the weaning phase. Why we are doing this? Because there are some recent reports, and this is going to be published in the Blue Journal, that if you have a high respiratory drive and excessive respiratory efforts, you have a deterioration of lung function in the following 24 hours. And for instance, these investigators were showing that if P.1 is very low, and then if you do a kind of occlusion maneuver that I'm going to explain later on in this presentation, you can, so both maneuvers are trying to measure the respiratory drive, the ventilatory drive. You can show that these patients, they do not have deterioration of lung function. But in contrast, if the patient keeps doing a very strong effort, these patients are going to deteriorate in the next 24 hours. So this is why in our strategy, it's part of the protective strategy to decrease the ventilatory drive of these patients. And the disease, the COVID disease is terrible for this. For some reasons that we don't understand fully, they have a very high ventilatory drive. And so keep an eye on P.1 and occlusion pressure during an expiratory pause, and this is going to help you to understand if your patient is protected. Okay, using this approach, we have shown that we can improve compliance along the days, in contrast with those patients in which we are following the conventional rules, so switching from volume control to pressure support and not using just the ARDSNet approach, following bit by bit the recommendations of the ARDSNet. These patients are working as a control group. So everything is guided by the computer. So we have these two arms guided by the computer. And it's interesting to know that just following these principles, I have an improvement in compliance in the following days. So I'm going here to the third day of mechanical ventilation, and then applying these two principles, which is the right amount of PEEP, not high PEEP, just the right amount of PEEP, plus avoidance of high patient effort, is going to improve your compliance along the days, helping you to keep a protective lung ventilation. It's interesting that at the beginning of the protocol, when the patients started to go to the next days of mechanical ventilation, and we were not yet reversing the paralysis or the sedation as we started to do, we are observing some deterioration of lung function when the patients were doing spontaneous effort. So we are reproducing exactly what you have seen in the previous publication in the Blue Journal. So these patients, they have a problem when they start the assisted phase of mechanical ventilation. There is some deterioration of your lung function caused by excessive muscle effort. Ideally, we should see something like this. And this is the first result of a protective strategy in 95, when you realized that high tidal volume was killing patients. So when we started to reduce tidal volumes and we started to avoid high driving pressure, we see a progressive improvement in compliance. So nowadays, we started to see some improvement in compliance applying the right amount of PEEP, but as soon as we did not take care of this high force performed by the ventilatory muscles or the inspiratory and expiratory muscles of the patients, we started to see a problem. And nowadays, we have a better understanding why this has been so difficult to realize and to treat at the bedside. So just an illustration that you have to pay attention to patient drive. So if we start using these two single approach, so right amount of PEEP and avoiding excessive patient effort, and obviously the rest of the package of protective ventilation, low driving pressure, low tidal volume, but especially low driving pressure, you can have a good result. And now that we are paying attention to these two aspects of mechanical ventilation, we are starting to collect the good results. So this is just a preliminary survival curve showing that we are moving in the right direction. Now we are going to blind this study, and then this was just a preliminary analysis to check if everything was going in the right direction. Now we are going to keep doing this study, only analyzing the results at the end to see if we can keep this promise of an improved lung function when we apply these two principles of mechanical ventilation, okay? So let's go over some few details of these two basic strategies. First of all, we have to understand that technology improved. So few centuries ago, we had only this to analyze the stars, and now we have this. And I think at the bedside, we have also started to see many new technologies that can help us to get a better lung protection. One of these examples is EIT, and giving us these online curves in which you can see what happens with collapse, overdistension, and lung compliance at each PEEP level. If you see these online, you can much better realize what you should be doing for this patient today. Because for this patient today, the best compromise PEEP is around this region. But maybe tomorrow could be a little bit different. And we have observed that this approach decreases a lot of overdistension that we were observing in patients using the PEEP FiO2 table of the ARDSNet. You can see here many regions getting bright white, which means overdistension. And then we can reduce overdistension when we apply the right amount of PEEP. And we can see a regional improvement in green of lung compliance in the ventral lung regions. So those regions that were white because they are overdistended, they get much better compliance after using the right amount of PEEP, which was lower in this case. Then we have seen also something interesting, which is a change in this behavior along the days. So the patient after 5 days, if abdominal distension decreased and lung weight decreased, can be a little bit different patient. And then we have analyzed patients along the days, and we have observed that we have somehow to adapt the strategy. And also we have to adapt the strategy according to the position of the patient. If the patient is supine, for instance, this patient was requiring 14 centimeters of water. But surprisingly, when we turned this patient prone, and this patient had a big belly, we can see that the sweet spot of PEEP increased. So this patient needed a higher PEEP in prone than in supine. So this was an outlier. Typically, we see a decreased need of PEEP when the patient is prone, but not always. And these are the important observations that we start to find when we take a closer look with, let's say, a better telescope to see the patients. Some other examples, and the literature now is full of examples of obese patients, patients under ECMO, that benefit from this detailed approach to PEEP titration, in which you find their sweet spot for each patient in terms of lung collapse and overdistension. And we have also used many different tools to improve the recruitability of the patients. So we use EIT at the bedside. We use some beds that allow us to change the positions of the patient. For instance, a patient that has too much consolidation in one lung, in the right lung, we typically put this lung upwards and started to apply PEEP to keep the good lung open in the dependent position. And then we just wait some time for the upper lung in non-dependent position to improve. So using a little bit of monitoring, positioning, and a little bit of recruiting maneuvers, we have tried to apply, let's say, the minimalistic recruiting maneuver, and then applying only in those patients that are very well, they are recruitable. For instance, this animal is very recruitable. It's self-evident looking at the DCT. But this other animal or patient is not recruitable. So how to identify at the bedside? Easy. Nowadays, we have an online display in some EIT devices that allow us to plot, for instance, how much % of your lung is recruited when you started to apply higher PEEP levels. And you can see that this patient jumped from 20% of the lung recruited to almost 100% at the end of the maneuver. I'm going to skip these PV diagrams, but also looking at the PV diagrams, you can understand what is happening. But pay attention to this other patient in which we are increasing PEEP during a recruiting maneuver, but the patient was already well recruited. So he started with 88% of his lung recruited and finished with almost the same amount. So we have these numbers now at the bedside to guide us. And then we are only applying a higher PEEP strategy in those needing. So it's possible in many patients that after PEEP titration that we have to decrease PEEP levels to avoid excessive overdistension in a patient with very low recruitability. So I have some few examples of what happened with individual patients, just as an illustration of this important aspect of individualization. So we are measuring here collapse. You can quantify very precisely with a very good correlation with CT if you are using EIT at the bedside. So, and then we are applying 2 levels of PEEP. So we are applying, for instance, 16 and 6 of PEEP. So here we see 6 of PEEP on the left and then 16 of PEEP. As you can see, when I increase PEEP, my degree of collapse decrease. And you can see that this happened with almost all patients except for this outlier. So these patients, these are COVID patients. So most of them, they needed more than 6 centimeters of water of PEEP, right? Because I could avoid a lot of collapse. But look at this. When I increase PEEP from 6 to 16, look how much overdistension I had, a lot. And you can see that almost all patients, except for few, bunch of 2 or 3, they increased overdistension. So you cannot blindly apply a high PEEP. You have really to select the amount in which you just avoid atelectasis, but you are not overdistending. And then if you, and just by chance, if you compare 6 with 16, just looking at compliance, you can see that compliance is almost equivalent, but for different reasons. So at 6 of PEEP, compliance is very low because you have a baby lung with lots of atelectasis. And here, compliance is the same because I have much less collapse. Remember, much less collapse. But so much higher hyperdistension that when you look at compliance is exactly the same. So when I look at the discompliance graph, I cannot tell you that 6 is better than 16 or vice versa. They are equivalent, in fact. So the only way we advance our lung protection if we stop saying high versus low PEEP, because this is not useful. You have to find the right amount of PEEP, right? Okay, there are some indexes of recruitability that you can use at the bedside. Laurent Brochard and Lu Chen have suggested this new index called recruitment to inflation ratio. And this index is now being tested in a large population of patients. They try to understand this recruitability of patients using a very simple and bedside maneuver. Our understanding that although this is a very interesting approach, in the future, with the improvement of technology, it's going to be much better to analyze the recruitability of your patients using a bedside and advanced tool like a telescope or like EIT in this case. And then it's going to be much easier for us to understand if the patient is recruitable or not. Okay. Some other details regarding the control of driving pressure during assisted ventilation and the patient effort during this important phase. We have shown that some patients, they start to have a deterioration in compliance when they are in the 4th or 5th day of mechanical ventilation because of this intense activity of inspiratory and expiratory muscles. So how to address this difficult question? So first of all, we have to remember about the principles. Driving pressure is a universal concept. So it's true during controlled mechanical ventilation and in many different scenarios, like this is the lung safe study showing that a high driving pressure is always associated with a worse prognosis. But this is also true in regarding 2 aspects. First, that the driving pressure is not only causing ventilator-induced lung injury. So high driving pressure is not only causing inflammation, it causes also lung fibrosis. So this is a long-term study in patients with ARDS, and we are demonstrating lots of fibrosis in these patients who survived the ARDS insult. And even after 6 months, they had severe lung fibrosis. But the interesting thing is that the fibrosis was closely related to the driving pressure applied during the first week of mechanical ventilation. The higher the driving pressure, the lower the vital capacity after 6 months. And the higher the collagen production found in the blood and tissue samples of the lung. So higher driving pressure was associated with a higher levels of mediators of fibrosis. Okay, this is one important principle. So because these patients with COVID, they have lots of fibrosis, whenever you're applying high driving pressure, you are implying in faster deterioration of compliance and lung fibrosis. And what happens during spontaneous effort? So the same principles apply. A few years ago, we were a little bit naive. Imagine that negative pressure ventilation was very different from positive pressure from the ventilator. We are hypothesizing that spontaneous ventilation was better because it was natural. Unfortunately, this was completely wrong, okay? Since the beginning, and the first studies analyzing the problems of ventilator-induced lung injury, they have shown that positive pressure ventilator or negative pressure ventilation, they cause the same problems, alterations in permeability and lung edema, shown here in pink. So even worse than positive pressure ventilation when applying the same driving pressure. And this worse performance is related to the fact that your venous return is higher during spontaneous effort. So at the very beginning of the history of ventilator-induced lung injury, we knew that spontaneous effort was not the solution. To avoid damage to the lung, you have to avoid high driving pressure produced by the ventilator or by the muscles. And then many studies have shown that no matter the mode of mechanical ventilation, no matter positive or negative or pressure control or volume control, if you are the mechanisms of lung injury, they are exactly the same, if not worse, during negative pressure ventilation. And I have had this experience with COVID patients. So many patients, they evolved to severe lung fibrosis during spontaneous ventilation. And then, in fact, when I put a little bit of positive pressure ventilation in these patients using the helmet, and I decrease the effort of these patients by applying a very personalized strategy with sedation, patient comfort, and the use of the helmet, I could decrease the fibrosis and lung edema in those patients. Okay? So basically, to apply this strategy, what we did is that we applied the helmet a little bit with a high flow nasal cannula. Why this approach is good? Because at the same time that I'm decreasing the dead space and cleaning the CO2, I'm increasing FRC and flattening the diaphragm, and then decreasing the efficiency to generate force by the muscles. And then a good clinical indication that this was working is that I could observe a reduced tidal volume measured by EIT. Typically, I found a decrease of spontaneous tidal volume by 30%, a decreased respiratory rate. And by doing this for 3 to 5 days, I could reduce a lot the injury found in some patients that were almost getting intubated. So remember, when we are addressing a patient that is jumping from the spontaneous phase, from the controlled phase of mechanical ventilation to the assisted phase or spontaneous phase of mechanical ventilation, your total driving pressure is the sum of what the ventilator is doing and what the muscles are doing. Whenever you have a strong patient effort, you are in trouble because it's, no matter what you do, this is going to increase the total driving pressure. And interesting enough, we found that this was absolutely true also during volume control ventilation, when you are strictly controlling the transpulmonary pressures. But because of the Pendeluft and heterogeneities inside the lung, this is not any longer true. So a high patient effort is always damaging. And this is part of our protective approach to patients with COVID. And then in the next class, and in my following webinar, we are going to address some more details about the assisted phase or during the phase of spontaneous ventilation or going to non-invasive mechanical ventilation. This is my final slide. So now we can open to some discussions, and eventually I'm going to show you some other aspects of this problem.